Welcome to another episode from your friendly neighborhood medical director. Today I want to discuss the approach to pain management in the pre-hospital setting. I think this is going to be an important topic for us to discuss, and hopefully you'll get something out of this. Our goals and objectives. Number one, we're going to discuss multimodal pain management. We're going to discuss opioid drugs. We're going to discuss some non-opioid drugs. And then we're going to learn an approach to pre-hospital pain management. So why does this matter? It matters because many emergency department visits and 911 medical calls are related to pain. So as you know, pain can be the result of an injury or our body's way of telling us there's a problem. Subsequently, we as providers are often called upon to treat pain. We all know that it sucks, that pain's terrible. We do have the desire and responsibility to advocate for our patients, but we do want to also deliver a cooperative patient to the ER. So here are some pitfalls in pain management. First of all, we're in the middle of a national epidemic caused by the overuse of and addiction to opioid pain medicines. We've been told for years that the pain scale is the fifth vital sign. Well, this is simply not true. Also, we've been taught the only way to address pain is through strong medicines. This is also not true. I think we can arm ourselves with some knowledge and take a humane and safe approach to treating pain. So, as you know, as you might imagine, there are pros and cons to using pharmacologic pain control. On the upside, we advocate for our patient, we decrease catecholamines, we get better cooperation with the examination and treatment, and don't forget about patient satisfaction scores. Those are a very real thing. So all of those things kind of play into why we should be treating pain. But for everything we do, there are downsides. For pharmacological pain management, the downsides include vital sign derangement, altered mental status, respiratory depression, the requirement of IV access, as well as the storage or access issues for the medicine itself. The DEA, as you might imagine, does not like it when we can't account for every last drop of our medicine. So let's talk about opioid drugs for a second. In general, opioids refer to the class of drugs that interact with the mu receptor to treat and control pain. Sometimes these drugs are referred to as narcotics, even though the word narcotic has a much more broad meaning. These drugs are categorized by the DEA based on their potential for abuse. So IV opioids that you will encounter in the pre-hospital environment, such as morphine, fentanyl, and Dilaudid, are all Schedule II drugs. Morphine is considered to be the gold standard by which all other opioids are compared. Morphine is an excellent pain medicine. Its technical dose is 0.1 milligram per kilogram, so a typical dose would be somewhere between 7 to 10 milligrams. However, most people start with 4 or 5 milligrams, depending upon the packaging. Downsides to morphine include nausea and vomiting, dizziness, and vasodilation. We can see hypotension from the vasodilation, but there may be a role in coronary artery disease, but this is controversial at best. Fentanyl gets a lot of press. Some of the press that it gets is worth the hype, and some is not. The reality is that street fentanyl is causing a large number of overdoses and deaths, and fentanyl is currently blamed for a large role of the opioid epidemic. The reality for us is that if we carry fentanyl, we buy it from a reliable source, we know it's the real thing, we store it, hide it, protect it, and give it in controlled doses. Fentanyl is highly concentrated. 10 milligrams of morphine analgesia is contained in 100 micrograms of fentanyl. The typical dose of fentanyl will be 1 microgram per kilogram. Most of us start with 50 micrograms and redose every 15 to 20 minutes or so. The nice thing about fentanyl is that it causes less alteration and mentation at our therapeutic doses and is relatively short-acting. This can be advantageous if we want to do routine neurochecks. Like other opioids, it can cause nausea, vomiting, and respiratory depression. Fentanyl has significant abuse potential, so make sure you give it only to those who need it and guard it with a safe surrounded by guard dogs and poisonous snakes. Dilaudid is another potent opioid. Many patients will ask for this by name. It's the one that starts with the D, but I can't quite remember what it's called. Dilaudid has 10 times the potency of morphine, so 1 milligram of Dilaudid is the equivalent of 10 milligrams of morphine. Dilaudid shares the same side effects of the other opioids, but tends to have more euphoria associated with it, which is why people ask for it. In my opinion, which belongs to me and me alone, Dilaudid does not have a role in the pre-hospital environment. Non-opioids include intravenous acetaminophen and intravenous Toradol. IV Tylenol was studied in several head-to-head pain control trials, with evidence that it has similar efficacy to morphine in a single dose. Unlike its oral counterpart, it crosses the blood-brain barrier and does so within about 15 minutes, which probably explains its efficacy. It is dosed the same as oral Tylenol and is relatively free of side effects. IV Tylenol is going to be a reasonable choice for pain, especially non-traumatic pain. Toradol is an anti-inflammatory pain medicine akin to ibuprofen. It can be given IM or IV. The good thing about this is that it affects inflammation, which is the root of most pain. The downside is that these medicines are hard on the kidneys, so there are a few people for whom this is not necessarily a good choice. Ketamine has quickly become the jack-of-all-trades sort of medicine. It has been in use for years by the anesthesiology community because it does have a favorable hemodynamic profile. Recently, within the past couple of years, the potential for pain control has been realized. At sedation and anesthesia doses, ketamine works as a dissociative anesthetic on the NDMA receptors. However, it can be given at a subdissociative dose of 0.3 milligrams per kilogram for pain control. This can give patients the heebie-jeebies, so we can avoid this by decreasing the speed at which it's given. Place it in 100 milliliters of fluid and give over 10 minutes. Some new information regarding inhaled or nebulized ketamine has recently come out, so you may see this coming to a truck near you. Never forget that simple maneuvers such as positioning, splinting, and ice packs can be very beneficial to your patients. Ice packs decrease inflammation while slowing down the conduction of nerve fibers. Splints may be helpful in reducing muscle spasm, and positions of comfort can decrease both pain and anxiety. So, to answer the question of what should I do? Well, first and foremost, have an open and honest conversation with your patients. Set expectations early. We're not going to take away all the pain. Perhaps we can make it tolerable. Maybe we can decrease it by 30%. We do have a responsibility to address pain, but not necessarily abolish it. We need to work within the confines of our protocols and understand that any medicine we give can have unpleasant or dangerous side effects. Start simple. Can I position them? Is ice appropriate? If you give meds, go slow and start low. We can always add more. Avoid time truncation. Set a timer to avoid overly aggressive pain assessments and dosing. We really should not redose medicine any sooner than every 15 to 20 minutes, but when they stare at us in the ambulance, it can be difficult not to address the pain. So really make sure that you have a very good approach, very methodological approach to giving your patient pain medicine. So in conclusions, I want to make sure that you understand the pharmacology of any medicines that you carry. Do not be afraid to use multimodal pain control. Use ice packs, use positioning, use medicines when needed. I'm not saying don't use medicines, but if we do these other things, we may not need to use all of the medicine. And then finally, remember, go low, go slow. We can always add more medicine. We can always add more things. Our goal isn't necessarily to abolish the pain, but just make it somewhat better. So let's do this in a safe methodological approach, and hopefully you can do a great job taking care of your patients. Much appreciated.